Hello, my name is Lynn Spina. Welcome to the workshop, Medical Marijuana and Stem Cell Transplant. What do we know? I'd like to introduce our speaker for this session, Dr. Joseph Bubalo. Dr. Bubalo is an oncology pharmacotherapy specialist with Oregon Health and Science University in Portland, Oregon. He is also an assistant professor of medicine in the Division of Hematology and Medical Oncology. Dr. Bubalo has been active in the clinical care of stem cell transplant and cellular therapy patients for over 25 years. He has received research grants to investigate ways to improve supportive care and decrease symptoms for transplant and other cellular therapy patients. Please welcome Dr. Joseph Bubalo.
Thank you for that kind introduction, and welcome everybody to our talk today. We're really going to explore, so to speak, what medical cannabis is and how it can possibly, when appropriate, be integrated into the care of someone who has had or is about to undergo a stem cell transplant. On your screen now, you can see kind of the traditional ways that cannabis was referred to. This really comes a lot from the drug use culture, as cannabis continues at a federal level in the United States to be a prohibited medication, despite the fact that it's been legalized in multiple states. And we'll talk a little bit more about this. But those are kind of historic terms that were used to describe cannabis products. We're going to really talk about how cannabis products may affect you as far as mood and or physical symptoms, what the products themselves can look like, and how you may want to think about evaluating them. Talk about potential benefits, if any, that are out there for a stem cell transplant survivor, and then focus also on potential adverse effects or interactions with other medications that you'd want to be aware of. Cannabis, and actually marijuana, has a long history in the United States. It came over in the 1800s with immigrants, and was one of the most prescribed agents through actually the 1800s. The major uses were things like labor pain, nausea, and rheumatism. After 1900, however, due to a variety of reasons, it became increasingly criminalized in the public eye. And in 1970, it was made Schedule I, meaning it had no medically acceptable use. However, in 2018, we now have our first non-synthetic cannabis product that was approved, a product called Epidiolex, which is approved for pediatric seizure disorders. Marijuana, or cannabis sativa as it's known, is a flowering herb. There are a variety of other species, mostly indica and ruderalis, that also have been used in medicinal ways. While it originated in Asia, it's literally an avid weed. It'll grow anywhere. So it's on all the continents except Antarctica, and it has kind of naturalized. So each continent has kind of a little different product. In the United States, it's now currently approved for medical use and sometimes recreational use in over 30 states. Every election cycle, one or two more seem to get added. On the states that actually don't allow medical cannabis or marijuana, a lot of them will allow low delta-9 tetrahydrocannabinol, or THC, which is the major psychoactive component in marijuana, to be used in some states, along with cannabidiol, which is a non-psychoactive cannabinoid that is in marijuana. So it's pretty available throughout the 50 states. When we look at what's actually in a cannabis plant, the main one of interest has been these phytocannabinoids. These are found mainly in the female flowers, and we know now that they bind to cannabinoid receptors in the body and change your body's responses to different things depending on what the person's state is at any point in time. And actually also differs with age, as the endocannabinoid system that these receptors belong to actually change as the body matures. Also, there are products called terpenes. These are aromatic chemicals that are found in almost all living plants, and they give each plant its unique scent. So the really strong, almost skunky flavor that is part of cannabis is mostly mediated by terpenes, and there's a variety of different terpenes or terpenoids as they're called, and they can give kind of a unique both smell and flavor to different cultivars of the plant. And they're thought that they may have some medicinal benefit, and that's in a very experimental phase of being looked at. And then finally, like a lot of plants, they have flavonoids. These are anti-inflammatory chemicals that are found throughout the plant world, and may have antioxidants as well. The most common cannabinoids that are going to be in any product that you purchase are going to be either THC, which is the major psychoactive component, and this is what was originally used recreationally to give someone a euphoria or a high. Originally, it was somewhere between 0.5 to maybe 6 or 8% THC that was found in most cannabis that could be purchased, and this was all illegally purchased at that point in time. And through a lot of selective cultivation, 20% is actually now on the low side. You can easily find products that are up in the mid or upper 30% THC ratings. Cannabidiol is really quite different in that it doesn't have psychoactive effects. You don't get high or get euphoria from cannabidiol, or CBD as it's known. It may actually decrease anxiety, however, and though it doesn't interact with the cannabinoid receptors, there's a lot of other receptors in the body that are impacted by cannabinoids, and is thought to probably work through a cluster of those, though they have not yet been identified. We do know, however, that it does modulate the action of THC, so it is not uncommon that you may see a mix of THC and CBD in a particular cannabis product in an attempt to reduce the psychoactive effects of THC, but still give medical benefit. And there are actually a lot of different cannabinoids, over 140 that can be found in the cannabis plant. Okay, the human endocannabinoid system has, as I mentioned, receptors. The CB1 receptors are these bright blues, and they're found mainly in the central nervous system. And these are the ones that mediate euphoria or a high, so to speak. The CB2 receptors, which were actually found about 5 years later, the CB1s were designated in 1988. In the early 1990s, they discovered the CB2s, and these are scattered around the body, and interestingly enough, they're clustered in immune areas, so lymph nodes, the thymus, other areas of the body that are responsible for immune effects have a lot of endocannabinoid CB2 receptors. And as I mentioned, CBD actually does not impact either receptor, but does modulate the effects of other cannabinoids. If someone is smoking cannabis or marijuana, generally 2 to 3 milligrams is what is found in the average marijuana cigarette, and that's enough to get someone into a euphoric state or high. The oral dose generally needs to be somewhere between 3 and 5 times that, because when you take it by mouth, the stomach acid breaks down some of the cannabinoids, and then the liver also metabolizes some before they get to the rest of the body. With smoking, it's a very quick onset time, generally minutes, whereas oral can take an hour to maybe even 2 hours, depending on how it's been taken, whether you have food in your stomach, and a variety of other things to actually feel the onset. So there's a different pharmacologic kind of timing to the effect. And the dose that's available, if you can purchase it in your state or country, is going to vary by where you live. In the United States, most states are looking at 5 milligram increments of THC as a normal dose or a divisible portion. Sorry, keep there. As far as drug interactions, we know that it does interact with a variety of body metabolic systems, and so you have the potential to either reduce the effect of other drugs or actually increase the effect of other drugs, depending where the other medications you're taking are metabolized in the body. There's also what we call dynamic interactions. So since it can be kind of sedating to take a THC product, if you're taking a sleeping pill or an antihistamine or an anti-anxiety agent, you see additive sedation or sleepiness. If someone is taking a stimulant for maybe like a attention deficit disorder, you actually may get less benefit from that stimulant if you're using cannabis. And then if someone is on a drug for depression or a psychiatric condition like schizophrenia or bipolar disorder, you can have pretty variable effects. And the concern there is that you may not have your normal level of control. There are some prescription cannabinoids that are available. Dronabinol, or Marinol, as it's known, is a synthetic THC in a sesame oil inside of a capsule, and this impacts both the CB1 and CB2 receptors. It's used mainly either for nausea or for appetite stimulation. Nabilone, or Sezamet, as it's called, is another THC mimic that binds in a very similar fashion that is used mainly for nausea, and actually in some countries it's used for neuropathic pain management as well. Cannabidiol is the product I referred to earlier as Epidiolex. This is a purified cannabidiol that comes from a single plant cultivar and has been standardized to 100 milligrams per mil as an oral solution. This is approved for 2 pediatric seizure disorders, and as I mentioned, CBD doesn't bind to either of the cannabinoid receptors that we're aware of. Cannabidiol, since it's becoming so prevalent, I think is kind of worthy of its own slide here. So at a federal level, it is considered a low THC, less than 0.3% content by weight type of hemp plant or marijuana plant. However, if you look in the community, you'll see whole cannabis-derived THC or CBD, and that may have somewhere between 5 and actually 30% of THC in it, despite the fact that it may be rated just for its CBD content. Interestingly enough, the cultivar that they use for the Epidiolex, the FDA-approved product, has less than 0.1% THC. So it is really pretty much a pure CBD compound as opposed to one that's modified in some way. So while all these cannabis plants that are out there are sativa or indica, it's really the cultivar that predicts whether it's going to have a lot of CBD or a lot of THC content. Just preparations that if you're looking into purchasing, that you may see available. Certainly there's marijuana. This is primarily what's sold today is flowers, the female flower, but you may see some leaves or stems which have a lesser amount of THC or CBD in a lot of them. There's a product called hashish, which is a concentrated resin, which may come as kind of a dark colored cake that can have pieces pinched off of it. Tinctures in cannabis speak are any liquid form of cannabis. So from a pharmacy standpoint, usually a tincture is an alcoholic mixture, but actually it could be soda pop, it could be anything that has cannabis infused into it may be considered a tincture. There's a lot of oils that are being extracted from this plant as an attempt to capture the cannabinoids that people want to use therapeutically. And originally, in the last 5 years, you saw a lot of different extraction methods, butane, ethanol, propane, CO2, etc. And a lot of these are actually dangerous to use. Butane, propane, for example, both are flammable and can explode, and occasionally the extracting people who are doing it in their homes would literally cause a fire or an explosion. CO2 is now probably the standard extraction method that is out there, and that's partly because it's less dangerous to use, but also because it's thought to leave less organic residues in any cannabis that is extracted. So it's probably a safer product from that standpoint. Infusions are when cannabis plant material are actually mixed with a non-volatile solvent, so it could be butter, cooking oil, etc., as you're getting ready to make the ingredients for a cannabis edible. And these edibles come in all kinds of solid and liquid forms, from snacks to drinks to things that could be on a main dish, actually, for a meal. And then, once again, a hemp product is mainly aimed at providing CBD, but depending on what cultivar it comes from, there may be THC present as well. When we think about natural products, these are quite variable as they're grown in nature. And there's also a concern about how they've been treated, whether there's been herbicides or pesticides that have been used in their growth to make them grow better, as much as you would in your garden. And that some states are testing for these, but it may or may not be completely consistent with every batch. They'll also be looked at for potency, and generally they're rated on THC content without a lot of regard for the other cannabinoids that may be present. So there may be a lot of variability except for the THC, and there are some products that will actually have a whole list of the cannabinoids that are present. And some consumers are very interested in these other ones other than THC. However, when we actually look at the labeling, which is very similar to a food label, if you look at the side of a food can, it'll tell you the ingredients from the most to the least, as well as preservatives or whatever. Over half of these products are going to be mislabeled. So there's not good quality control between the label and what you're actually getting. And sometimes that's challenge just because even with the same cultivar, depending what time of year it's harvested, what the sun, rain, soil contents and exposure have been, you can end up with a fairly different batch from the cannabinoid content. And we're still actually trying to figure out what an appropriate medical dose is. So anytime I give you a dose, that is an educated guess. Synthetic cannabinoids are out there. They emerged in the early 2000s, and it was found that there were other chemical compounds that could actually cause people to get euphoria or high. There are 7 major groups, and you'll see them mostly in convenience stores, gas stations, etc., under a variety of names such as Spice or K2 or Fake Pot, etc. These are all now Schedule 1, and even if you more than regular cannabis, they have no acceptable medical use and a lot of toxicity associated with them. There's been cases of kidney injury, heart attacks, all kinds of contamination, including with even poisons. There was a big contamination of product with a rat poison a few years ago. So these are really unsafe compounds, and I would recommend avoiding them. So let's look at the medical use of cannabis. When we think about the effects, we really are usually directing them at whatever the effects of THC are. So if we think about what people expect to see, the psychological aspects, changes in behavior, so you're going to be more buoyant, laugh, easy. You may have sensory changes, and this is usually some kind of time and space perception alteration, and disorientation is actually fairly common. When you're thinking about how functional you are, it's really common to be drowsy, you may get dizzy, you may be less coordinated. And then when you're thinking, nobody thinks better on cannabis, especially THC. So you're more likely to be confused, especially short-term memory lapses are common, and concentration is difficult. So this isn't something that improves your testing skills. When we think about the potential uses, there are many. And as I mentioned in that first slide, it's been used since the 1800s in the U.S., so it's not surprising that there's a lot of interest here. And as noted in that slide, pain and nausea are the top 2. Then the other things that have been looked at are certainly appetite. We now have an approved product, the Epidiolex, for seizures. And there's actually another one out there that is in phase 3 testing for muscle spasms in multiple sclerosis patients. So there is evidence of potential benefit, and we're just trying to figure out kind of where it fits in. Pain management this is a new guideline that came out last year. Canada legalized cannabis nationwide about 3 years ago now. This is their first attempt at actually putting out a guideline. So I'm actually going to use their guideline this year because the U.S. has nothing as advanced as this. So who might be helped? So if there's who out there could consider using it and maybe getting benefit. So if you have moderate to severe either cancer or non-cancer pain, or if you have nerve type pain. These guidelines are strictly from a pain standpoint. Those are the two types that are likely to be helped. Who should not be using it or may not be helped? It's not advised to be used in children. Canada suggests not using it in veterans, and it's unclear why that is. People with mental illness, as I mentioned earlier, you can lose control of your illness control. And then people with disability benefits are involved in litigation. I think that's some kind of medical legal thing. The guideline does not recommend either inhaled cannabis, that recreational use has any application to the management of pain, and then they actually don't suggest it in end-of-life care. So what are the potential benefits and how likely is someone to get benefit? And this is the first time I've seen this, so I thought it was really interesting to look at. 1 in 5 people actually have a reduction in pain, so it's not everybody, clearly. With that reduction in pain, 1 in 7 actually had improved physical functioning. There was no change in emotional function, so it was no different than placebo. So if someone has an emotional condition, anxiety or whatever, it doesn't appear to really benefit that when used for pain. It's not different than placebo in most roles, so whether it be your work role, your life role. Social functioning, it does not change. And about 1 in 6 people had improved sleep quality, and whether that was from better pain management or from the cannabis itself, it's unclear. The potential harms that they found was that 1 in 3 people had impaired attention, and that's those kind of disorientation I was mentioning. 4 out of 5 people had more drowsiness, so it's quite sleepy time drug. And then 1 out of 2 had some cognitive impairment. So as I mentioned, people are not thinking clearer when they're using this. So the recommendations that they are saying is that to use cannabis only if standard treatments have been tried and are not working. If using, they want you to use a non-inhaled form of cannabis, and we'll talk a little bit more about why that is. And then generally this is an add-on therapy. You're not going to replace your standard therapy. You're going to add this on if you meet all these criteria. So their key recommendations is it should be started at a low dose, non-inhaled product, and they want to use cannabidiol products, not THC. And then you can gradually increase the dose and then add THC depending on both your response and whether or not you tolerate it. Prior cannabis experience should be considered. So if you're someone who's used before and you would want to monitor for side effects, you'll have more likely an expectation of whether or not you're going to get benefit and whether you can tolerate the side effects. Young people, cannabidiol is preferred as THC appears to change neurocognitive development. And so there's really concern about exposing anybody under the age of 21 and maybe under the age of 25 as you may not reach your full mental potential if you use it early. And then you should avoid driving or operating machinery when you're using this, when you're changing doses. And there's a recent paper that suggests that you should not use it within until at least 4 hours after taking a dose. And then those that are pregnant or considering becoming pregnant or are breastfeeding should discontinue the use because it will be passed on to their fetus, born or not. So is there harm from cannabis? As a drug, it is generally less addictive, considered less dangerous because unlike fentanyl or heroin or something, you really can't overdose on it. So the overdose risk is relatively small, which makes it a kind of a soft drug, and when we think about other recreational drugs. The side effects, if we were to compare the two prescription products, dronabinol and nabilone, and then cannabidiol as it's now used in seizures, and then regular marijuana or medical marijuana, you could see that as we kind of break out these different cannabinoids, there are differences that are seen. Cannabidiol, for example, tends to decrease appetite, whereas we see increases with medical marijuana and nabilone, and dronabinol is actually FDA approved for that. And you can look through this table and see that there are changes based on, and you would expect to see changes based on the cannabinoid content that is in your product that you purchase. So we've talked about using only orals. Smoking and vaping are problematic from a medical point of view because you're delivering particles when you burn that cannabis into your respiratory tract. And you get about 4 times, actually, the number of particles when smoking marijuana that you do from smoking a tobacco cigarette. And that's mostly because of the way people inhale and hold their breath when they're smoking marijuana in an attempt to absorb more THC. When smoking, the combustion is actually really hot, 600 to 900 degrees Celsius, and this produces a lot of toxic byproducts, tars, hydrocarbons, carbon monoxide, and ammonia. When you vaporize, the combustion is at a lower temperature, and you generally see less carbon monoxide and higher, but you're still getting absorption of other things. So while vaping is probably safer than smoking, it's still not a recommended way to deliver cannabis. And you do probably get more THC out of vaping than you do out of smoking it. But whether that's truly less harmful, either from the byproducts or decreased pulmonary symptoms, it probably is, but it's hard to know what the long-term effects are. As far as the effects on lungs and breathing, when someone chooses to smoke, you see a fair amount of wheezing, there's increased sputum production, and there's a chronic cough, but you don't actually see chronic obstructive pulmonary disease as you do with long-term cigarette smoking. And we don't know if that's because people haven't been doing it long enough or it's truly going to be different as far as the long-term impact on the lungs. We're most worried actually about the risk for pulmonary infections, and especially those that are immune compromised, like someone after a stem cell transplant. From a bacteria standpoint, Enterobacter is the most common bacteria that we see contaminated, and then the most common mold is Aspergillus, which is a pretty aggressive pathogen in the stem cell transplant population. The dry buds actually are more dangerous than the oil. The processing of the oil actually reduces spore content, but does not eliminate them. There's a lot of case reports with certainly people who have died from Aspergillus infections. And there are some other countries, Israel actually for one, has looked at sterilizing cannabis, but it's not routinely done, and certainly not in the U.S. There has been questions about smoking cannabis and lung cancer, and there's this single study, what we call a case control study from New Zealand, where they looked back at people who smoked a lot of cannabis, and they found that there was a similar risk of lung cancer based on what they call joint years, which was a joint a day for a year, versus pack years of cigarette smoking. But most of these people who smoked cannabis also smoked cigarettes, so this is pretty confounded at this point, but it's certainly not a zero risk. We do know that it does, when you smoke it, that it changes the blood flow through the heart. You get increased rate, increased blood pressure, and some people that can cause problems as either sudden cardiac death or stroke has been seen. You can also see some changes in heart rhythms or arrhythmias, which can be problematic. So this is another reason that we try to stay away from inhaled cannabis products. Young people, as I mentioned, the endocannabinoid system is critical for brain development and maturation, both physical and mental. So those that have a lot of adolescent exposure tend to have long-lasting alterations. We know that genes get turned on and off at different times in life, as you're supposed to grow at certain times and maybe not grow at other times. But we know that early use of cannabis products can result in changed behavior and cognition that last into the adulthood. And as I mentioned, brain development probably goes until the age of 25, while we have legalized this for 21 and older. So we try to stay away from it in anybody who's younger, certainly younger than 21. With animals, we do know that young animals show some fetal malformations and risk for growth retardation. We have a fair number of babies that have been born to people who are using a variety of substances, and those with cannabis tend to be a little lower birth rate, weight, and they may have some delayed visual symptom development. And then they kind of also, sometimes these babies will be kind of tremulous and have some lack of muscle control, which may be a form of withdrawal from cannabis. It's hard to see. As you follow these children into their adolescent years, they tend to have more delinquency and some problem behaviors, but this is very hard to tell just because adolescents are so variable anyhow. There is concern, however, that it is going to predispose them to mental health conditions. While it's not considered as addictive as some drugs, there is a dependence that can form to cannabis, and this happens in about 1 in 10 people. It's certainly less than nicotine in regular cigarettes or heroin or alcohol, and it's about the same as the sedatives like a benzodiazepine like Ativan or something on that order, and cocaine addiction. The risk is greater for smoked versus eaten is thought, but that's not been proven, and we now do see that some people who use orals do become dependent upon them. And if you use them long enough, there will be some physiologic withdrawal symptoms if you stop suddenly. In general, with driving, it doubles the rate of auto accidents, and these tend to be not that you're not like you've been drinking alcohol and you have that profound loss of coordination and kind of thought that alcohol can do to you. This tends to be a loss of autonomic reflexes. So you forget to turn on your turn signals when you're going to make a turn. You are less likely to hit the brakes in response to a brake light in front of you, things like that. And April 20th is this national kind of pot holiday. And if you look at 1 week before or after, around April 20th, you have a 12% increase in fatal car crashes. So, and then there's a recent study where they took almost 200 people, and these were experienced cannabis users, and they would have them drive a track in a parking lot, and then they would have them go ahead and take cannabis and try to repeat that. And actually, out to about 4 hours after a dose, even though these were experienced users, they had poor scores on their driving course. So it's thought that probably at least 4 hours should elapse between taking a cannabis dose and driving. As I mentioned, with the fungal infections, these are really worrisome from an inhaled product, and all types of cancers and transplant patients have experienced this, even in the non-oncology setting. It tends to be associated with longer use and with smoking cannabis thus far. And we know that smoking it deposits the spores in the lungs of at least half the people who use it. As I mentioned, there is not really a process to sterilize it currently. In the immune-compromised, the aspergillus is most concerning. And whether you smoke it or vaporize it, it does not kill these spores that are, and molds, bacteria that are on the plant surfaces. And I just threw in how it is sterilized in other countries. You could bake it yourself if you wanted, but this is going to also change the THC content, which is sensitive to heat. So when we look at cannabis, this is really framed as a third-line use, not first line. So you want to look at it and see, have you tried the standard of care, and is it working for you or not? If it's not, often they'll have you use a second product if there is one available before they consider adding something like cannabis to that. The areas where it's been beneficial are nausea control, especially around the time of chemotherapy, certainly appetite, like wasting illnesses, chronic pain, especially neuropathic pain. And then, as I mentioned earlier, there's a trial looking at muscle spasms associated with multiple sclerosis, which looks quite promising. And generally, you're going to use it after the first and second line approved products are going to be used. You would want to actually consider using a FDA-approved cannabinoid like dronabinol if that's clinically appropriate for your use. Anybody who has a history of either substance use problems or has a psychiatric diagnosis, any kind of unstable mood, is probably going to have that worsened if you're using THC-based cannabis products. And then you're going to have to be in a state with a Medical Provider Practice Act or a medical marijuana law that allows you to meet that. Anytime you buy it and take it across state lines, you are doing a federal crime. So kind of our take-home points from a risk standpoint, smoking it, even with vaping, you're at risk for lung cancer and other kind of side effects. If you smoke it, you're going to increase your risk for heart attack or a stroke, especially in the elderly meaning 60 and older. And anyone who has a psychiatric disorder, especially schizophrenia or bipolar, is probably not going to have as good a control over that disorder if they decide to use cannabis. And it's particularly concerning if they're a young person, whether they have a psychiatric disorder or not. It is certainly less habit-forming than nicotine and other hard drugs, but there is a real risk of dependence, especially in young people. We worry a lot about prenatal exposure, so when the mom is pregnant or is breastfeeding. And then, once again, older adults and with chronic illnesses, we don't have great history with that, and we're concerned. So benefits, as I was going to, your take-home points. We really are still figuring out the medical benefits and where it is a benefit. Clearly, we have an FDA-approved product, and seizure disorders are an area of promise. These are people in these disorders who have many, many seizures a day, sometimes 40 to 60 a day. And with the use of the cannabidol CBD product, they will have reduced numbers, but they usually don't go completely away. Pain relief, especially neuropathic pain, we know now that somewhere around 1 in 5 or 1 in 6 people can get benefit. Muscle disorders, especially spasticity is of interest. Certainly appetite and nausea are of interest. And actually mood is kind of what a lot of people report benefit out. They just feel better. And that is still hard to characterize. But currently, this is, and I need to emphasize this, it's not recommended first line for any of these. It's going to be an add-on therapy. So while kind of we started out looking at the names that have been historically used for cannabis, the thing, if you go into a dispensary now, and if you're going to buy this, you should buy it from a dispensary. You'll be able to get a certificate of analysis that's been looked at for fungus, for pesticides, for herbicides, all these things. But the names have clearly changed. These are all kind of fun names for the most part, as opposed to those that were more associated with the drug culture. And with that, I would be happy to open it up for questions.
Thank you, Dr. Bubalo, for your very excellent presentation and comprehensive. We'll now take questions. As a reminder, if you have a question, please type it into the chat box on your lower left-hand corner of your screen. So our first question is, this patient writes, as a young patient going through the physical and psychological effects of cancer, I have consumed marijuana, mainly food, in order to calm my anxiety, reduce pain, etc. However, I have felt fear that it might negatively interfere with my treatment after 3 years of transplant. Can marijuana cause leukemia relapses or negatively interfere with the bone marrow?
That's an excellent question. We don't. The bottom line is we don't know. But there is a new class of cancer therapies called immune checkpoint inhibitors. And we have seen now, it was first a case report, and then now there's a second series that has been published, where individuals who use immune checkpoint inhibitors and are consuming cannabis at the same time actually have a decreased response rate to these checkpoint inhibitors. So how does that apply to transplant? We know that when we do your bone marrow transplant, your stem cell transplant, that we are giving you a new immune system, and this new immune system then seeks out the cancer cells and eradicates them and prevents relapse. So if and we know that the CB2 receptors of the cannabis, of the endocannabinoid system, are scattered throughout the body, mainly in areas of immune activity, thymus and lymph nodes and whatnot. And the concern is that if you are going to use cannabis regularly, that you may actually be putting yourself into a state of immune suppression, which would then maybe increase your risk for relapse if you have residual leukemia. So I actually share your concern. We do not have evidence that it does that, but there's this hint from these other cancer agents make us a little more concerned than we had previously.
Important to know. Thank you. Can medical marijuana help with ongoing digestive issues after an allogeneic bone marrow transplant, which can contribute to an inability to gain weight and a sort of wasting away syndrome?
So the use of cannabis is really to increase appetite, and then it's kind of up to you what you can do with that appetite. So it's an increased desire for food and an increased desire to take in maybe certain types of food, and but it won't if you had graft versus host disease of the GI tract and you're having impaired absorption right now. It actually won't improve absorption of the food, though it will improve your appetite. So the hope would be that with the increased volume of eating, that you would actually end up getting in more calories and better calories. But it actually will not. It won't heal the GI tract. That's only going to happen with time.
Thank you. Here's another GVHD related question. Any data on CBD in chronic lung GVHD? What would be the recommended dose of CBD to help with lung GVHD? I read a study where CBD was used to prevent acute GVHD after allogeneic transplant, and the dose was quite high.
Yeah, so we're I have no advice actually on CBD dosing. The dose goes all over the place, and certainly the seizure dosing is quite high. It's like 20 milligram per kilo, so that's maybe as high, depending how large you are, it's 500 milligrams and higher in most people per day. So those are big doses, and they, as you can see from that one slide, you are going to see side effects, decreased appetite and other things. The study you're referring to, where there looked like CBD might decrease the incidence of graft versus host disease, was interesting, and I think food for thought as to maybe a way, once we're able to get good products, that would be worth looking at in a larger number of people. The concern is preventing it is much different from treating it after it's happened. And I have not seen good evidence at this point that it will help GVHD. And so the concern, and I actually don't know what the dose would be at this point in time. That would be the next part. Would be a kind of a dose finding study to figure out where, if benefit is going to be found, we would have to start the dosing.
Thank you. I'm going to throw out another GVHD question for you. See if there are studies that can help answer this. Can medical marijuana reduce the inflammatory sclerotic effects of GVHD on the skin and nerves, leading to sclerosis and peripheral neuropathy? So
potentially it could, in that, as we know, it has these flavonoids, which are anti-inflammatories, and then we were talking earlier. Will it change the immune system? So if it actually does downregulate the immune system, while it increases your risk for relapse, it might decrease the effects of GVHD, including sclerotic, which tends to be more responsive sometimes than other types of GVHD. So I don't. Once again, the answer is I don't know, but there's certainly a possibility. This would remain to be seen. At this point, I have not seen any evidence, however, that it will do that. Nobody has done that study.
Okay, thank you. You mentioned a little bit about this question, but maybe you can elaborate on it. Can it help with musculoskeletal pain and muscle spasms?
Yeah, so the product that is out there is a 1-to-1 ratio of CBD to THC, and it is used as a nasal spray, much like you use a steroid spray for seasonal allergies. And for multiple sclerosis, they will spray up to. I have not actually seen the prescription labeling, but it's multiple times per day. And they will use it to reduce spasticity. So it doesn't help with muscle pain, but it appears to help to relax muscles. And this is the first product that is at a prescribed ratio. So it's a 1-to-1 CBD to THC, so you have less of the psych effects, less high, less euphoria, less changes in your thinking, and it appears to relax the muscle rigidity, which can come from multiple sclerosis. So this is not yet FDA approved, but it could be available actually within a year or so.
Interesting, thank you.
It's approved in other countries at this time, sorry.
Great. This next question is a two-part question. Are edibles safe with elevated liver panels? Are they safe while on Tasigna?
So all of the cannabinoids we've seen so far are liver metabolized, and at high doses they do appear to increase the liver function test assays. So we don't know if they're actually causing harm or this is just some part of their metabolism. So if you have decreased liver function and the high liver panels are a symptom of that or a measurement of that, you may not metabolize it normally, and it could irritate that. We do know that the cannabinoids, especially cannabidiol, are dose-dependent inhibitors of drug metabolism. What that means is that the higher your dose of CBD, and the more likely you are to actually interfere with your Tasigna. So I would actually not recommend taking a CBD product with Tasigna because it will change the metabolism. You may get unexpectedly high Tasigna levels and side effects related to that.
Thank you. Do you recommend smoking marijuana after transplant? Perhaps you can elaborate, Doctor, on the whole aspergillus issue.
Yeah. So at least when they looked at crops of marijuana, they found that at least half of them had fungal spores on them. Interestingly enough, it's at least a quarter of the cigarette tobacco that's out there also has the same fungal spores. But we have many case reports and case series of people who use cannabis by smoking and actually ended up giving themselves a fungal pneumonia, some of which were actually fatal. That is truly the concern with any type of inhaled cannabis product. Currently there is no way we can prevent you from contaminating your lungs with fungal spores, and as long as you're immune compromised, you are at increased risk for infection as those spores deposit there. We see less bacterial pneumonias, but the Enterobacter or Enterobacteriaceae species that is commonly there is a risk for a bacterial pneumonia. It's mostly but those are usually treatable with antibiotics. The aspergillus, unfortunately, is not always treatable. Sometimes they have to actually surgically remove a lung, and depending on how much lung space you have, that may or may not be an option for you as well.
Okay, thank you. Does marijuana does it interfere with medication, especially sirolimus and aclovir?
The acyclovir. So it does not interfere with acyclovir. Acyclovir is just cleared by the kidneys, and that's actually not interfered with. None of the cannabinoids are cleared by the kidneys. The sirolimus actually it would increase and prolong sirolimus levels. So we would not recommend taking the cannabis along with sirolimus. The same would go for cyclosporin or tacrolimus. Those two agents, you wouldn't want to take along with cannabis. It will change your levels, and once again, since the products are kind of unpredictable, the change in the level would be unpredictable as well.
Good to know. And can you talk about synthetic marijuana?
Yeah, synthetic marijuana, so this is just a chemical, and as I mentioned in that slide, there's 7 different chemical classes, and all it does is make people high, basically. It has no medicinal value whatsoever, and in fact, it causes harm. The worst is it causes kidney failure, but we've also seen some other effects from it. And so these are just chemicals that folks have found by experimentation that cause them to get high. They're dangerous. They're not really meant for human consumption. They have no medical testing whatsoever. So if somebody's selling you a synthetic marijuana, that has a higher harm rate than actually marijuana itself.
Okay. How do I find a dispensary?
So dispensaries are only available in states that sell medical cannabis. And interestingly enough, every state is different. You'll have some that are actually run by pharmacists, which is something that we have to learn after pharmacy school because they don't usually teach it in pharmacy school. And there are other states that are completely run. Oregon, where I live, for example, they have a education program that is not really official, but the people who sell it in Oregon dispensaries are called bud tenders, and they have a broad experience from a variety of ways with cannabis products, and you go in and you discuss with them what your goals are, medical or recreational, and they can direct you towards a product that you can then experiment on yourself with, because once again, each of us perceive it a little different. So each state has a different way of selling it, and it would depend where you live. If you don't live in the U.S., I have even less knowledge about that. You would have to see what your local regulations are. Well, we do recommend that if you are going to use it, you do get it from a dispensary. They'll be able to give you assay records to look at purity, pesticide or herbicide exposure, whether or not it's been tested for fungus, and what the rate of spores are, that kind of thing. The fungal testing is not great. What Oregon does, for example, is they test the moisture content, and the moister it is, they give it a higher rating of fungal contamination.
Thank you. Do you recommend a CBD cream?
We are still trying to figure out what to do with the CBD creams. They are absorbed, but it's so variable we have not been able to actually figure out a percent absorption. And the other thing is a lot of CBD creams are being added to other stuff like a Bengay or other topical muscle pain type of cream and then massaged in. And I have never, at this point, seen a placebo-controlled cream study to say that it's actually better than placebo. But so there's a lot of activity around it. I'm a hiker. I get Backpacker magazine, and there's all kinds of CBD creams in there if I want to rub them on at the end of the day. But yeah, I've not actually seen evidence as to what type of pain it's beneficial for, and then how much to apply and how often.
Thank you. And this will have to be our last question. And it states, what is a recommended THC level in medical marijuana for anxiety and also nausea?
Yeah, so for anxiety, there is actually not a recommended product at this point. Most people, if you are going to use cannabis for anxiety, they would recommend probably an indica variety rather than a sativa variety. And there looks to be maybe better evidence for CBD for anxiety than there is for whole plant marijuana-based cannabinoid. So if you're going to try something for anxiety, I would recommend a CBD product after you've once again gone through the normal medical channels for the first, second, maybe even third line products to consider. For nausea, Marinol actually is a well-tested product. It's pretty widely available in the U.S., and I would recommend you try that. And the dose of Marinol that works for you or doesn't work for you might give you insight into the cannabinoid dose that would work for you. For THC, for nausea, somewhere between 2.5 and 5 milligrams would be your starting dose. We know that most people, once you go over 15 milligrams of THC, you tend to see more side effects and less benefit. So, and unfortunately, everybody has to kind of experiment on themselves. We don't actually, outside of the Marinol, we don't have good dosing recommendations at this time.
Thank you very much. And this will have to conclude our Q&A session. And on behalf of BMT Infonet and our partners, I'd like to thank you, Dr. Bubalo, for your very helpful remarks, and thank you, the audience, for your excellent questions. Enjoy the rest of the symposium.